Subcommittee on Health will now come to order. As a 24-year Army veteran, I've seen firsthand the struggles that many service members and veterans face in light of their service, which is why I'm excited about this first House Committee on Veterans Affairs hearing on the potential for psychedelic-assisted therapy treatments in the emerging battle against suicide, or as we like to say, emerging therapies or breakthrough therapies. I'd also like to say that as a physician who practices traditional medicine, I never thought I would enter Congress to be then advocating for emerging breakthrough therapy, but I think the science is leading the way. The VA dedicates a considerable amount of its budget and resources in pursuit of evidence-based treatments for veterans who suffer from post-traumatic stress disorder and other cognitive disorders. For many veterans, this treatment is life-saving, but more work needs to be done. It is a sad reality that close to 17 veterans per day will lose their lives to suicide. One life lost to suicide is one too many, and our fight must continue. Psychedelic-assisted therapy is a groundbreaking clinical procedure that has the potential to transform the way we look at mental health care. A licensed clinician carefully examines a veteran prior to administering a dose of a compound, such as MDMA or psilocybin. A veteran must go through 2 or 3 sessions, during which intense psychotherapy is overseen by a licensed medical professional assisting the veteran throughout the experience. These sessions last about 8 hours, the full duration of the drug's effects. Based on the most recent clinical trials, patients experience positive therapeutic responses, resulting in a reduction of their symptoms, if not remission altogether. The fight against suicide and substance abuse goes hand in hand, as substance use disorder can lead to higher suicide rates among veterans. Therefore, we can't be afraid to explore new treatment methods, especially the ones that we will hear about today, that have proven to transform veterans' lives and are done in a clinical and a scientific manner. Still, we must argue and urge caution when speaking on this topic. We are not advocating for the legalization or the casual use of psychedelics. What we are discussing is the clinically administered dosage of these substances in combination with targeted therapy sessions in a clinical setting. I look forward to hearing more about the process and progress that the VA and our private healthcare partners are making in advancing what could be a new way of treating the debilitating mental health conditions that affect our veteran community. I'd like to hear what next steps are anticipated, as well as what challenges, including bureaucratic barriers, safety concerns, workforce, and others that should be addressed in moving forward. I'm also looking forward to hearing from our second panel on the positive personal impact this therapy option has had on their lives and in successfully treating their PTSD. I want to reiterate, we are not advocating for the legalization or casual use of psychedelics, but rather the advancement of science, of their medicinal properties in a clinical setting with assisted therapy. Thank you all for being here, and I look forward to our discussion and hearing the multiple perspectives based on the incredible expertise present today on both panels to discuss this important topic. With that, I yield to Ranking Member Brownlee for her opening statement.
Thank you, Madam Chair. I look forward to hearing more today about the potential therapeutic benefits of psychedelic-assisted therapies for veterans. The landscape of psychedelics has evolved significantly in recent years, and we are at the brink of a new era in which these substances, once stigmatized and misunderstood, are being examined for their potential to address mental health and addiction challenges. And we need to make sure that the Department of Veteran Affairs is keeping up. Veterans are continuing to die by suicide at rates higher than the general population. We know that pharmaceuticals and certain types of therapy are not enough for many veterans. Many post-traumatic stress patients do not respond to traditional medication-only treatments because traditional medications are only treating symptoms such as insomnia or anxiety. As our RAND witness points out in his testimony, up to 30% of patients drop out of evidence-based psychotherapy treatments, and more than half who do complete treatments still retain diagnoses of post-traumatic stress. We need to look at all available treatment options, and one of them is the topic before us today. While the research in psychedelics has been limited, it has shown promise. However, as the chairwoman said, it is our duty as members of Congress to ensure that treatments offered to veterans are both effective and safe. We must weigh the risks and rewards carefully, recognizing the need for safeguards while also fostering innovation at VA and other federal agencies and expanding treatment options. This is also an exciting topic because at a time when much of Congress is polarized and partisan, this is one area where many of us on this dais agree that more should be done to research psychedelic-assisted therapy. I look forward to the discussion today about what VA is already doing and whether Congress needs to take action to change existing statutes, whether more can be done to bolster research, and whether there is opportunity for greater involvement by VA in this research. Some in this room today may be skeptical about the wider use of psychedelics. I'd like us to remain committed to the principles of rigorous research, thoughtful policy, and patient-centered care. Veterans have given so much of themselves to our country. Our ultimate goal should be to promote the health and well-being of veterans and make sure that we are providing them with the very best care possible. They deserve nothing less. With that, Madam Chair, I yield back.
Thank you, Ranking Member. Thank you, Ranking Member Brownlee. On our first panel, we have Dr. Carolyn Clancy, Assistant Undersecretary for Health at the Office of Discovery, Education, and Affiliate Networks, Department of Veterans Affairs, Dr. Ilse Weikers, Deputy Executive Director at the Office of Mental Health and Suicide Prevention, Department of Veteran Affairs, Dr. Rachel Yehuda, Patient Care Director at the Bronx VA Medical Center, Department of Veterans Affairs. Dr. Clancy, you are recognized for 5 minutes to deliver your opening statement.
Good afternoon, Chairwoman Miller-Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee. Thank you for the opportunity to discuss VA's ongoing clinical trials involving emerging therapies and specifically psychedelic-assisted therapy. Accompanying me today, as you noted, are Dr. Ilse Weikers and Dr. Rachel Yehuda. The VA is committed to safely exploring all avenues that promote the health of our nation's veterans. VHA continues to effectively advance the health and well-being of veterans through the exploration of innovative, safe, and ethical emerging therapies. Every study in VA is conducted under stringent safety protocols. Our focus isn't just on finding the best innovative treatments for our veterans, but on doing so safely. This is especially true for studies that test compounds such as MDMA and psilocybin as part of an intensive psychotherapy program to treat veterans with PTSD, depression, and other mental health conditions. We've also been monitoring psychedelic research outside of the VA and will continue to evaluate the scientific evidence those investigations uncover for possible use in our future studies. There is still much to learn about the potential benefits of psychedelic-assisted therapy. VA researchers are conducting several studies on the use of psychedelic-assisted therapy for the treatment of mental health conditions. To date, the studies underway have been funded by outside organizations or philanthropic foundations. VA ensures these treatments take place in a safe clinical environment and use pharmaceutical-grade medications under carefully controlled conditions. Potential participants undergo comprehensive medical and psychiatric screenings to make sure it's safe for them to participate. Furthermore, dosing of psychedelic medications is performed only by trained staff who know how to monitor for adverse events. Last month, the VHA held a state-of-the-art conference on psychedelic treatments. This conference provided us a better understanding of the current state of scientific evidence, allowing us to create a strategic framework for future psychedelic treatment research. It also identified the necessary steps for potential system-wide clinical implementation of treatments with FDA approval. This conference also determined a need for clinical trials that enroll a unique and diverse population of veterans. Rigorous studies of VA patients are important because they often have mental and physical health challenges that can reduce the effectiveness of a treatment. VHA trials would build confidence that the results accurately represent an expected clinical response in veteran patients. Psychedelic treatments are far from the only emerging therapy the VA is researching for the battle against suicide. We're also leveraging technology to offer non-pharmaceutical approaches to help veterans address the day-to-day challenges related to anxiety, suicide prevention, and acute and chronic pain. For example, in March of this year, our researchers reported that transcranial magnetic stimulation is effective as a treatment for depression, even in veterans with traumatic brain injuries. We also have a study examining the use of a stellate ganglion block to reduce PTSD symptoms. This procedure could be a method that expands the range of evidence-based PTSD treatments available to veterans. VHA also developed a 60-site clinical demonstration pilot to address suicide as it relates to pain, deploying 300 virtual reality headsets to VA providers across the country. That pilot will also test the use of positive environments to distract from negative stressors and build both coping mechanisms and resilience. We are really excited about the potential of these treatments. We're combining these innovations with strong research to evaluate and assess health outcomes. Even as we encourage new and effective interventions, the VA will continue to fully implement current evidence-based interventions that move mental health treatments forward. We appreciate the committee's continued support in this shared mission, and my colleagues and I look forward to answering any questions you may have.
Thank you, Dr. Clancy. We'll now proceed to questioning. As has been my directive in the past, I'll put myself at the end of the questions. I now recognize Ranking Member Brownlee for any questions she may have.
Thank you, Madam Chair. My first question is to you, Dr. Clancy. Good to see you again. It's been a while. Is it already possible for the VA to fund research on psychedelic-assisted therapies, or are there statutory or regulatory barriers that Congress would first have to address?
There are no statutory barriers. This is a highly regulated environment, so as Dr. Yehuda, my colleague from the Bronx, could describe in great detail, this requires that investigators invest a considerable amount of time in getting approval from the FDA and the DEA, down to the precise doses that will be used in the treatment. We have not done anything to discourage this, but I think the time frame of getting all these approvals has been a bit of a disincentive to some researchers. Do you want to add anything to that, Dr. Yehuda?
Thank you. The VA research program works on a peer review basis, so nothing precludes a VA investigator such as myself from writing a grant, but because of all the steps that are necessary to conduct this research, it's often difficult to get all of that work done in that kind of a framework. So I think this is something that will become easier in the future.
Very good. Dr. Clancy, you, in your testimony, too, you talked about funding virtual reality research and demonstration projects. I'm sort of curious to know how much funding has gone into that, and have you given any consideration to directing similar levels of funding towards research on psychedelics?
Those are the conversations that we're having right now. I will take for the record and be happy to get back to you about how much we have invested in virtual reality. These are not pure research studies. They really come out of our innovation portfolio. So in some cases, we are buying headsets. In other cases, we are working under something called a cooperative research and development agreement with various companies that make these headsets. They're wildly popular, to put it mildly.
Thank you. Dr. Wiekers, am I pronouncing that name correctly? Are providers at VA permitted to discuss psychedelic-assisted therapy with veterans if they have questions about it? I fully understand that we are still in the experimental stages here, but as word of the potential benefits of some of these therapies, veterans may have questions that they would like to discuss with a physician. So are there any limitations around discussing this with it all?
No, in fact, I would hope and I would encourage our veterans to actually openly have these conversations with their providers. We want to encourage our veterans to share any information that they've received or that they're considering about potential participation in one of the available research studies, or if they were thinking about using recreationally, we'd hope they'd have a conversation with their VA provider first, so that we could help ensure that they have all the information that they need. But there's nothing in policy that would prevent our providers from having those conversations with the veterans when they have questions.
Great, thank you for that. This is a question for really any of you, but are any of you aware of clinical trials focusing on the potential effectiveness of psychedelics for women veterans, particularly women veterans with post-traumatic stress? I'm always advocating for, particularly when we talk about mental illness and so forth, that different therapies are going to work better for women than men, vice versa, and that we need to be thinking specifically about both genders as we approach this.
I don't believe that anyone is focusing exclusively on women with PTSD, but we totally agree with you about the urgency of the need. A much higher proportion of women veterans have PTSD than men. There are smaller numbers, so absolute numbers are different, but it is something of very high interest to us. We have a number of studies ongoing now, not funded by VA, but funded by private foundations and so forth. And we will get back to you about how many women are involved, but I'm quite confident we're not at the place where we're going to have the statistical power to say anything conclusive.
And Dr. Clancy, you talked about creating a sort of the future framework of research around this area. So do you have a time frame for that?
Not at this moment, but we will be following up with you. I can absolutely guarantee that.
Thank you. I yield back, Madam Chair.
Thank you, Ranking Member Brownlee, and I'm just going to add in that 50% of NYU or New York University trials involve women. The chair now recognizes Representative Bergman for 5 minutes.
Thank you, Madam Chairwoman. First of all, I have a personal request for all three of you, and that is, you know, the VA has the best hearing aids in the world. I have not gotten there yet to get mine, so if you wouldn't mind when you speak into the mic, pull it close. It'll help me hear a little more clearly. I'm sure my colleagues can hear just fine, except for Dr. Murphy, who keeps saying what. But anyway, Dr. Clancy, great to see you again. It's been a while. Dr. Yehuda, it's great to see you. And Doctor, this is the first time we've met, so I'm looking forward to hearing more from you. But Dr. Clancy, in your testimony, you state that more research into MDMA-assisted therapy, especially research including more veterans, is needed before the VA can take any next steps. As you may be aware, Congressman Lou Correa from California, Lou and I came in together as freshmen back in 2017. We introduced an amendment to the Milcon VA appropriations bill during directing VA to conduct a wide-scale study into this treatment, which was approved unanimously on the floor. Now, having said that, just because something gets approved on the floor, now the next steps falls, into your bailiwick. Now that the House of Representatives has shown its support for these efforts, will VA commit to advancing large-scale research into MDMA-assisted therapy to treat PTSD in veterans?
There's no question that we will be actually funding a number of studies, and I will commit right here that we will be keeping all of you informed just as soon as those decisions are finalized.
Good. Is there any barriers right now that exist that you could foresee that you could be willing to share with us so that we can kind of be proactive here?
No, the barriers Dr. Yehuda and I described earlier all have to do with going through the requisite regulatory approvals from the FDA and the DEA. There's not a shortcut there, but I know a number of our colleagues are excited about the possibility. Not that they think this is the answer, but they are inspired by hearing from veterans whose own experience has been very, very positive and want to be part of learning whether that is a generalizable finding for many veterans.
And will the publication of phase 3 clinical trial results with that last month, all signs point towards MDMA-assisted therapy receiving FDA approval within the next year. What steps will the VA take before then to have therapists trained and ready and to prevent bottlenecks to ensure that the veterans in need don't have to wait years to actually receive the treatment? Because we know one of the limiting factors here is going to be have those trained therapists ready to take that veteran through the experience.
Yes, so for all of the studies that are ongoing right now in VA, all of the therapists have gone through that intensive kind of training. A few other people have sought this training from the organization MAPS on their own because they see this as part of the future and a skill set that they would very much need. I can assure you that at our state-of-the-art conference, the whole question of what's the right research strategy and how do we plan right now for implementation would make sense. I'm going to turn to Dr. Wiekers, who will explain briefly that we have a pretty good track record here.
Thank you, Dr. Clancy. So I think there are a lot of unanswered questions that relate to what will actually come out of the FDA approval process and the steps that will need to be taken in terms of ensuring we have trained providers, that we are following what we anticipate will be a REMS, a risk evaluation mitigation system that will be...
And I don't want to cut you short because I know you've got a lot of data to share.
I see the time is ticking
You know,
down.
in warfighting, training and readiness is everything, and we train in advance knowing the fight's coming.
Yep.
You know the fight's coming, in this case, a good fight. So the more proactive the VA can be, we're here to help to knock down any barriers. And my time is short. Dr. Yehuda, I understand these therapies, patients are administered the medication on site and are at no point given any kind of supply to take home. Do you feel there is any potential for recreational misuse of through these therapies?
Thank you, Congressman, for your question. In our experience thus far, I don't think that there is going to be opportunity for misuse. One of the most common things that veterans say after receiving MDMA-assisted therapy and working hard processing traumatic memories is, "I can't believe they call this ecstasy." And most veterans have told us that they would not seek out recreational use of MDMA on their own. I think that veterans are very happy to have these treatments in the safety of a clinical setting that they have come to trust. And it is not only the provision of the medication, it is also the psychotherapy that allows them to open up about very difficult experiences so that the environment is really ripe for this.
Well, we've seen your operation, and I appreciate you allowing me to go over a minute because we have to make sure that the guardrails are up to not only minimize but eliminate abuse and misuse of these substances. And with that, I yield back.
Thank you, Representative Bergman. The chair now recognizes Representative DeLuzio for 5 minutes.
Thank you, Madam Chair. Good afternoon, everyone. I think one of the things you will hear across dais here is we all want to make sure that my fellow veterans can receive the treatment that is safe and effective, and so I encourage that research. I want to see federal law not be standing in the way of pursuing treatment that could be safe or that you're finding is safe and effective. Dr. Clancy, I'll start with you. In your testimony, you wrote, or you write that the VA complies with all applicable laws, rules around psychedelics and research. I know Ranking Member Brownlee asked about funding. General Bergman asked a similar question, but my question is, are there any statutory barriers for the VA to conduct research on psychedelics, cannabis, any other Schedule I substances?
There are no statutory barriers, no.
So that being the case, well, let's start with cannabis. Is VA doing research into cannabis? And if so, what does that look like?
We have about 10 studies ongoing right now, and they range from basic science to what we call health services research, which is how does it work in healthcare every day. Of the 10, 2 are clinical trials. 1 focuses on PTSD, and 1 is focused on reducing pain, or assessing whether it can reduce pain in a meaningful way.
And ongoing research?
Yes.
Okay. And do you have an expectation of timeline and when you might see results?
I don't know that right at the moment. Again, happy to take it for the record.
Thank you. Dr. Clancy or Dr. Wiekers, if you're more appropriate to respond here, please feel free. Shifting back to psychedelics, if these studies show that any of these treatments will be safe and effective for whatever conditions, does the law prevent the VA from ultimately pursuing a treatment? What stands in the way beyond FDA approval, should that ever come?
Well, I'm just going to take a key from Dr. Wiekers a couple of minutes ago. FDA approval will almost certainly be accompanied by something called a REMS approach, risk evaluation and management strategy, which may be straightforward and it may be quite complicated. So that will be something that we would obviously review very, very carefully. But that's not a statutory process. Right. This is all about effectiveness and safety.
And I guess then on both psychedelics and cannabis, is there anything Congress needs to change should your research and what happens at the FDA suggest these should be safe and effective treatments for veterans?
Not that I can see, no. But we would be in touch if we thought otherwise.
In terms of research and funding, are there funding issues? How can this body and the Congress help if there are?
I think you can help, and you are helping by having this hearing, the roundtable a few months ago. And we have appreciated Congress's support of particularly this committee for our research budget. And again, I don't see anything else there, but thank you.
Very good. Okay. Madam Chair, I yield back.
Thank you, Representative DeLucio. The chair now recognizes Dr. Murphy for 5 minutes.
Thank you, Madam Chairman, and thank you guys. This is very, very intriguing. I just met with some folks actually a couple times today, and exploring this, being a scientist myself, I'm going to probe this pretty hard, and don't take anything personally, but it's just like we were pimped in medical school and everything else. So can somebody give me a little bit of a historical scenario? Where did this start coming out? Were folks coming in and saying they use these stuff recreationally and they were helped by it, or how did all this, what was the genesis?
To the best of my knowledge, some of this work dates back to the 1960s, if not earlier. And then there was a hiatus. I'm going to guess the Controlled Substance Act passed in the early 70s had something to do with that. I think the people from the organization MAPS, unless Dr. Yehuda knows more about the history, could actually give us a more recent timeline. It's not that there was suddenly a campaign. This has been growing for the past few years. Witness Congressman Bergman's, insertion into law a few years ago.
Does anybody really definitively know mechanism of action? I know it's serotonin, but anybody specifically know where that's going to hit or what it does?
Thank you very much for that question. We don't specifically know the mechanism of action of psychedelic-assisted therapy, and one reason for that is that an active ingredient in the treatment, in the clinical efficacy, comes from the combination of administering a psychedelic plus the psychotherapy. So we know how these compounds act in the brain. We know what receptors they target. We know that they may build avenues for brain plasticity. But the real task ahead of us is to conduct research that will answer that question, and specifically, why taking psychedelic medicines in the context of a safe container with trained providers can facilitate an insight and introspection and galvanize healing. So this is very important.
Is this thought to be really therapeutic or maintenance? In other words, what's our schedule here? Is it, are we thinking that 2 or 3 therapies are curative, or is this something that we think our vet's going to have to take lifelong? Is it going to be a subset of patients, all of the above?
I would say that's why we're continuing to do research. We've certainly met veterans for whom this appears to have been curative. The real test, obviously, will be for how long a period of time and so forth, but I think it is too early to answer a very logical question like that.
And subsets of patients with pre-existing, cardiac disease, arrhythmias, there has to be some exclusionary criteria for some individuals, just because these things are not like taking Tylenol and not like taking aspirin. I will just say one of these things. We had an occurrence, I guess it was 3 or 4 weeks ago, where a pilot who was sitting in a jump seat took some magic mushrooms recreationally. And he had taken those 3 days before, and then he tried to bring down a plane. And then he got restrained in the back and then tried to open the back of the door. So, these things are not magic bullets. They are not without consequence. I want us all, and I applaud your work on trying to help this. This is amazing if it can be done, but it would be naive to think, one, there are not repercussions, and two, there's not going to be abuse, because people will find a way to abuse these medicines because it's a drug and it's one of these things that will be abused. But putting guardrails up as stringently as possible is going to be critical, because we're going to get doctors who are not the best doctors in the world that'll go through a course and will become prescribing mills just like anything else. But keeping this well within guidelines is going to be absolutely critical from day one, not 5 years afterwards when we see people ruining the system, but from day one. And there is, to General Bergman's point, there's going to be an onrush of individuals. I personally, and I'll make a plug-in, I still am a firm believer in hyperbaric oxygen. I know the studies are somewhat controversial on that one regard, but just in the same vein that you're saying try to touch these individuals who cannot be touched, why would we not do anything that can't be? One quick question, is there any comparison to scopolamine with any of these things that are being done?
Not that I'm aware of.
Okay. All right. Good luck on your work. Be stringent. No predetermined outcomes, and let the evidence take you where the decision should be. Thank you very much.
Thank you, Dr. Murphy. The chair now recognizes the ranking member of the full committee, Mr. Takano.
Thank you, Madam Chair. A few months ago, Dr. Elna Hall, the Undersecretary for Health, and I visited Loma Linda VA healthcare system, where we met with Dr. Shannon Remick. She's leading a phase 2 clinical trial examining MDMA-assisted psychotherapy in veterans with combat-related PTSD. She was quite likely the first VA researcher since the 1960s to administer a psychedelic as medicine to a VA patient. I am proud to have this groundbreaking research going on at the VA Medical Center that serves my constituents. So my question is to Dr. Clancy and Dr. Wiekers. I understand that there are currently 5 clinical trials involving psychedelic-assisted therapy going on at VA medical facilities. To what extent is there interest from other VA researchers in getting involved in this research, and how is VA supporting it?
So a big reason that we had the state-of-the-art conference in September was to actually bring together some of the best and brightest within VA, as well as across the federal government and from some of our affiliates, to really assess the answer to that question, because it's an important one. I will say that for people in our system who invest a fair amount of time in providing care to people with PTSD, they were inspired and very hopeful, and hoping that more science, like you've described at Loma Linda, could get us to a place where we can know if this is a breakthrough for veterans, and which veterans, and how do we do that safely, and so forth. It would be hard for me to overstate their enthusiasm. But as you and your colleagues have said, we've got to make sure that it's both effective and safe.
Dr. Wieker?
I would simply say yes. To echo what Dr. Clancy said, we have actually a large and robust kind of de novo community of researchers and clinicians across VA who have interest in this work, who've taken it upon themselves, many of them, to seek out education and training in this space, and who are enthusiastically looking forward to becoming more involved, both in the research and anything beyond that as the opportunities develop.
Well, thank you. Dr. Clancy, in your written testimony, you explained that VA and DOD determined the current evidence regarding MDMA was insufficient to include it as a recommended treatment in their latest clinical practice guidelines for the management of PTSD. I think I came in as you were saying, maybe it's a little too early. It was released, those guidelines were released in June of 2023. How many clinical trials would you need to have published? Or how many veteran clinical trial participants would there need to be for DOD and VA to consider including MDMA in their clinical practice guideline?
I don't have a precise answer to the question because it depends both on the size, and right now there are not enough veterans that we would feel comfortable in terms of saying that this works that well for veterans, notwithstanding the fact that there are 2 phase 3 trials that are showing promising results. But it's also about the quality of the studies, how clearly and safely were they conducted. It's easy to say we're going to randomize people or enroll people with these specific characters and have other exclusion criteria. The real question is, did they actually manage to come up with that? And ultimately, the FDA is going to decide in terms of whether they approve this.
Okay, so we have another agency that.
Yeah.
How far away would you say we are from achieving that level of rigorous study and sufficient evidence? You know, if we were to have optimum support from Congress, my sense is that there's strong bipartisan interest in supporting VA and encouraging VA to move aggressively in this area.
Well, I have huge, deep respect for the FDA's process. I would say that evaluating a treatment that is a combination, as Dr. Yehuda so clearly described, of psychotherapy plus a drug will challenge how they've been evaluating processes before. I'm quite confident that they will, but I would not be betting on a timeline.
Thank you. And what barriers, if any, are there to conducting multi-site studies of psychedelic-assisted therapy, where researchers at multiple VA medical centers would partner to enroll participants, adhere to the same study protocols, and pool their data?
You know, one of the core strengths of our research program is multi-site studies, and over the past few years, starting, interestingly enough, just a little before COVID came on the scene, but it turned out to be hugely helpful, was a way to make it easier and far more efficient and quicker for us to stand up multi-site studies. So I'm not seeing a problem there at all.
All right, well, thank you. I'm over time. I yield back.
Thank you, Representative Takano. The chair now recognizes Representative Luttrell for 5 minutes of questions.
Thank you, Madam Chairwoman. Dr. Wickers, so the Deputy Executive Director for Office of Mental Health and Suicide Prevention, you arguably carry the heaviest rucksack in the VA, and I applaud you for that. I can imagine the challenges. And in the past, we've had hearings where they're breaking out the numbers to us out of your department, and it's an exponential growth rate in the wrong direction. It's really hard to wrangle. My colleagues have stated, and Ms. Clancy, you can answer this one as well, but we are, I would say, they may argue with a united front behind the efforts and the well-beings of our veterans, and this seems like the next level proverbial tool you can put in a toolbox to save the lives, to increase the quality of life and decrease the symptomatic issues. The VA seems to be actively engaging with Congress and moving forward in the right direction, but my concern is that it dies on the vine between the communications between the VA and possibly the FDA. In conversations that you're having, please be honest. In conversations that you're having, can I even say be honest? I can say be honest, right? Please be honest. We need to know, and the veterans behind you would love this answer too, is the FDA seem like they're playing ball with us in order to get this thing moved accordingly? Dr. Wickers, you can go with that one, or Ms. Clancy. Because you've kind of, Ms. Clancy, Dr. Clancy, you've kind of talked around it a little bit. I'm not trying to get on you or anything, but I need the answer. It sounds like the FDA is not fully engaged on this.
First of all, I don't actually have a way to assess that, but I did.
You wouldn't, okay,
Yeah.
Who does?
Right. Well, they are an independent body, and they have very, very serious responsibilities. I have no doubt whatsoever, because I have full confidence in the FDA commissioner currently, that there's any reason for them to be foot-dragging here.
Yes,
I
ma'am.
think this is a tough challenge.
I can appreciate the responsibility the FDA has, but the members sitting on this dais right here, when we walk around our districts, we have to talk to the families that lost their veterans. And there is no more serious a situation than that. Again, so if it seems like there's a friction point that this may stall, we want to engage.
Okay.
Dr. Yehuda, can you please share with the committee just some high-level results from your research so we can go home? One of the challenges, and if anybody in the room has a creative name besides the word psychedelics, we're eagerly awaiting that to hit. But can you share with us some results that we can share with our base and the rest of the members of Congress that may be a little apprehensive on us pushing this forward?
Thank you very much for your question, Congressman, and thank you for your service. Yes, we're in the middle of a study. We have now randomized 17 combat veterans to receive MDMA-assisted psychotherapy. And while we haven't completed, except for 10 veterans, I can say that I'm extremely encouraged by what we have seen, and there's every reason to be extremely optimistic that this is not only a therapy that can help veterans reduce their PTSD, but also give them a way to reconnect with their purpose and mission and find ways for them to be more integrated with their families and societies. So we're very, very hopeful. But I don't want to get ahead of the trial that is in process. Just to say that there's really every reason for optimism and investment.
Thank you. So the committee, we're basing our right and left flank off of the science. I'm a scientist by trade, a neuroscientist by trade, before I became a congressman. And we're looking for the empirical data. We are. And I understand this space lives between science and spirituality. I have often said, and maybe this committee may not know, but I have gone through these treatments. And it's something that I would, for me, this is Morgan saying this, I would never, ever tell anybody to do it. It was such a challenging experience, but life-changing. And I think, as the chairwoman said, given the proper guardrails for those who need it, not for those who want it, that is where the magic happens. I could use some scientific terminology, but I don't have one in my head right now. Mr. Murphy left. There's no rules and regulations, Mr. DeLuzio asked a great question, that prevents the VA from moving forward on this. I would like to see the VA leading this. Our veterans are ready. Our veterans want to move away from the selective serotonin reuptake inhibitors and all the other tools that may not move the needle as much as they can and break this proverbial tool out to go, hey, you know what? If we're at this point now, let's make this a thing, okay? My time's up. Thank you so much, Madam Chairwoman.
Thank you, Representative Luttrell. The chair now recognizes Representative Landsman for 5 minutes. Thank you very much. That's the most rapid set of questions we've had. The chair, and relevant. The chair now recognizes Representative Kiggins for 5 minutes.
Thank you, Madam Chair. Just a couple questions about the criteria when we're talking about who's eligible for some of these clinical trials. Are there any disqualifying factors like addiction, criminal charges, or when we have to choose who's going to receive this in the initial treatments, what are we looking for?
Thank you very much for the question, Congresswoman. Yes, every clinical trial has exclusion criteria, but they're designed to protect the patient from potential adverse effects if they're vulnerable. So, for example, patients receive a cardiovascular workup, but we don't look at things like if they're in the justice system, because it's not a medical reason to exclude someone. So, yes, the exclusions are designed to be protective. Currently, they're quite conservative, and one of the reasons that we need to do more research is because as we become comfortable with these treatment approaches, we can see who else can fit under the tent. And so this is a very important part of the kind of work that has to be ongoing so that we can make this really as generalizable as possible and as safe as possible.
I know that with some other controlled substances, the VA does a great job with things like drug contracts and making sure that we're doing periodic drug screenings and pill countings and just really staying on top of people who are prescribed things like opioid medications. So will we have that same type of kind of safety tracking mechanisms in place with this type of treatment?
In our clinical trial, the patient receives the medicine from a physician, and we watch the patient take the medicine. There's no opportunity for diversion. So again, this is as safe as it gets. Nobody is going home with anything. So it is really happening under controlled conditions. And also the patient is being monitored in terms of biometrics. So there's every opportunity to look at whether something may need an intervention for the patient's safety.
So will you be doing randomized drug screenings? I want it to, if we're going to do a clinical trial, just making sure it's as pure as possible so they're not going home and using or taking maybe other substances. So how are we ensuring that the results we're seeing are truly the result of the treatment they're receiving in-house?
A lot of what we do before we administer MDMA therapy is we do preparation. We do a lot of talking about what to expect in a psychedelic experience, what it's for, what the person's intention is, and what are the kind of barriers or reactions that might be anticipated. So all of these things are discussed. If a person will then develop a craving for a substance, that will be discussed in the therapy. But so far in our experience, that is not what happens. I think people are not using the psychedelics to alter their state in the sense of getting high or avoiding. They're using this medication in the context of facilitating an insight, of allowing them to connect with traumatic material, to build empathy, to build self-compassion, and to be able to confront things that they just haven't been able to confront before. So the idea isn't let me feel good from a drug. It's let me put myself in a state that is most conducive to safely exploring material that is very difficult. So it's a very different paradigm than the paradigm of drug-seeking behavior in order to avoid and forget. This is seeking a medicine that helps you engage, and it is sometimes very difficult in the room. And that there's an opportunity to do that work with the veteran, especially if the workforce, as it is in the VA, is very well trained and well versed in what it means to talk about very difficult, traumatic, war-related material.
I hear you, and I can appreciate those things. I just want to make sure that we are, again, conducting a clinical trial that is very pure in its sense, and it doesn't have other factors, because I'm sure that this is a group of people that is fragile. And I think of patients with mental health issues aside, and there's a lot of sad stories out there that they've tried. So I just want to make sure that we are being protective of this treatment so that we can have the most accurate results. So that's my only concern. And last question, I just want to know what, if any, if we know of any long-term side effects from these treatments.
We haven't encountered serious long-term effects yet, but that is one of the most important things that we have to do. It's often the endpoint of clinical trials is maybe a month or at the most 3 months following treatment. But really what's important here, and the VA affords the opportunity to do this, is to really look down the road and see if the gains are maintained, what else pops up, how the patient engages in healthcare and mental health care, and what else we can offer in a different way to the veteran.
I just wanted to add one brief point. Every clinical trial in VA and many, many other places has a data safety monitoring board, so they're constantly, this is an independent group. For example, if the results were so stunningly positive that it would feel almost unethical to continue, for example, a placebo group, the trial will be stopped. On the other hand, if some adverse effects emerge that would also question whether we should continue this trial. So this is all independent, but that's part and parcel, and we will certainly be watching that very, very closely.
Thank you. I yield back.
Thank you. The chair now recognizes herself for 5 minutes. Certainly, whether we're talking about emerging breakthrough therapy or we're talking about standardized conventional care, doesn't every clinical trial, randomized controlled trial for a drug go through a process by which patients are excluded from the trial? You're trying to get as pure results as possible. Would that not be true for any type of therapy? Yes, no?
I would say yes. It's just that it's a little bit different. There isn't one single science like pharmacology or pharmacotherapeutics, right, to guide what would be inclusion and exclusion criteria. So clearly, studies like the one Dr. Yehuda is leading and others, I think will be highly informative to us in the future.
Yes, certainly, this isn't only a chemical that's being administered, there's psychotherapy, so that's a little bit different and a little more convoluted or difficult, I would think, for the FDA to seek approval. And Dr. Yehuda, so the Bronx VA is not the only VA that is doing these types of studies, and there are also similar studies going on through other research institutions and medical facilities as well, is there not?
Yes, I believe so.
I think the evidence and the literature would confirm what you just said, that yes, there is. Dr. Clancy, at the VA hosted psychedelic state-of-the-art conference, one of the key gaps in research identified was the need for more trials conducted with veterans. What's the VA's plan to address this obvious gap, i.e., are you setting up to do more trials or to expand the number of admissions into trials?
That's a topic that we're working through right now, and again, we look forward to sharing our conclusions when we've made those decisions.
And is it not true if there were, let me give an example, a drug for high blood pressure that was approved by the FDA, how long would it take for the VA to then prescribe that medication for individuals, or a statin for cholesterol?
Well, in the case of pharmaceuticals, we have a very active pharmacy evaluation group, and I'm mangling their official bureaucratic name, that meets almost immediately, and that has allowed us to do...
But would it take 5 years? Would it take more clinical trials?
I mean,
to both Representative Bergman and Representative Luttrell's point, the concern that we have is that even after FDA approval of MDMA-assisted therapy or breakthrough therapy, that there will be a long lag time until the VA starts instituting that. So I guess what we'd like to convey, or some of us would like to convey, is that we think the VA should be preparing for that ahead of time.
Yes.
We know that there'll be workforce issues. We know that the types of veterans that will seek this therapy, and that utilizing both the research within the VA as well as the research outside of the VA that's being conducted be brought into that. Because certainly the FDA is not looking only at the research the VAs are doing, but they're looking at the research that's occurring at other research institutions.
Yes, no, I think we agree with you completely. And I'd just like to ask Dr. Wiekers to, again, stress that we have a strong track record here, and this was a very important theme at our conference.
Thank you, Dr. Clancy. As an example, previous emerging therapy, intranasal esketamine, or Spravato, was FDA approved in March of 2019, and we treated our first veteran inside VA at the Boston VA in July of 2019. It took about 4 months for our Pharmacy Benefits Management National Formulary Committee to go through its standard operating processes to review all of the information from FDA and to make its own determination about the status within VA, and then for us to stand up with building upon some expertise at facilities that were already providing ketamine treatments to then utilize the intranasal esketamine treatments. And then we expanded thereafter and now have 42 sites across VA providing either ketamine or esketamine treatment today.
Well, we would hope if the FDA approves this, there would be the same rapidity of treatment. As we know, ketamine has a dosing issue and more addictive potential. When I think SSRIs were discussed, so when we're talking about medication that we currently utilize in addition to therapy and psychotherapy for veterans for depression, so whether it's anxiolytics, antidepressants, these medications have a side effect profile that is fairly significant. So whether it's foggy brain, whether it is multiple medications, alteration of medications, there's a side effect profile that so far, and I think Dr. Yehuda alluded to this, you've not seen that same side effect profile as you have in the studies that you're doing.
Yes, because the drug isn't administered continuously. The drug is taken just a few times. And so there are things that happen during the course of the day that are monitored very carefully. And then what we are on the lookout for is whether there are other kinds of changes in mood or physiologic states that occur over time. But this is exactly the work that we have to do in the future to make sure that this is safe for everybody to take.
Thank you. I yield. The chair now recognizes Representative Baczynski for 5 minutes.
Thank you, Chairwoman. And thank you to the witnesses for joining us today. Addressing the behavioral health needs of our veterans has really been one of my top focuses and priorities as I'm honored to serve on this committee. As we know, veterans face unique traumas while in the line of duty, and many face these struggles alone and without the care they need. I just hosted a Veterans Town Hall when I was home over the Veterans Day holiday, and I heard very much firsthand from the veterans in the district about access to more behavioral health treatments was critically and is critically important. And I really want to be a part of the solution, but I also really want to ensure we're doing so in a way that builds off of a solid base of evidence. Psychedelics have shown promise in early clinical trials, especially when combined with therapy. However, the scope of clinical trials and research into these psychedelics for veterans is still limited and in early stages, as I understand. For example, dropout rates in trials among veterans is relatively high. Co-occurring medical and psychiatric disorders need more research, and cultural diversity among trial participants has been very low. Some of the concerns that I have. I also want to make sure we're including women veterans in these trials. As we know, they face very unique experiences in the line of duty as well. I've heard from many women veterans, including those on my Veterans Council, about military sexual assault trauma they've experienced, and we need to ensure that we include in any clinical trials for psychedelic assistance that taking that into account, I think. And so I want to be clear that I do support the use of psychedelic-assisted therapy for our veterans, but I want to make sure we're not rushing the process and potentially putting veterans in danger. I support a robust government funding at the VA directed toward more extensive research to fully examine the potential positive effects and consequences these therapies can have on our veterans community. And so with that, I do have a question. My first question, if you don't mind, Dr. Clancy. If psychedelic drugs receive FDA approval to treat psychiatric disorders and DEA reclassifies these drugs, what steps does the VA need to take to help scale these therapies and make them more broadly available?
When it is approved and when we have enough evidence with veterans for all the reasons you just so clearly described, one of the big steps would be making sure that we had appropriate training. There are some other issues that we would need to be exploring. For example, 1/3 of the veterans we serve live in rural areas. So for those veterans who live in rural areas and have broadband, you know, can this be done virtually? That's not happening in this country, but I learned at the conference that in Europe, some studies are pursuing this and so forth. But it would be a whole process of scaling, very similar to what Dr. Wiekers just described in terms of starting the first treatment for veterans with ketamine or inhaled ketamine and then building out from there. So we know how to do this. And we take enormous pride and care about making sure that it's safe and well done.
Yeah, I appreciate what you've shared specifically about rural communities. That definitely reflects concerns I have within my district and those unique challenges, especially when you're looking at trials. I don't know if anyone would like to add anything beyond that, beyond what Dr. Clancy shared. Okay, and then I just had one other quick question with the time I have. How can researchers encourage veterans from various racial and ethnic backgrounds, and women in particular, as I mentioned, to participate in clinical trials to help ensure that trials are representative of the veteran population?
I'm really happy you asked this because, again, for all the reasons that you stated a few moments ago, the population of veterans we serve now is far more diverse. Gender, racial and ethnic background, and so forth. So that's very high in our minds. We've got a group in our Office of Research and Development very much focused on both enrolling more diverse patient populations, but also, quite honestly, identifying and encouraging future scientists from multiple backgrounds. So that will be a challenge for sure, but important.
Okay, great. Thank you. I'll yield back. Thank you, Chairwoman.
Thank you. On behalf of the subcommittee, I want to thank you for the testimony and for joining us today. I'm sure that we could have many more questions, some of which we may submit for answers later. You're now excused, and we'll wait for a moment as the second panel comes to the witness table.
Yes. The only one left, please.
Am I still here to gavel again? Because I'm going to make this stop.
About 3:25, I gotta leave. Yeah. Thank you. I'll be right back. Okay. I know you've got to leave too, so.
Well, I don't have a substitute.
I start? Welcome, everyone, and thank you for your participation in today's hearing. Joining us today is Sergeant Jonathan Lebecki, U.S. Army retired and a psychedelic therapy clinical trial participant, Dr. Frederick Barrett, Associate Professor of Psychiatry and Behavior Sciences at Johns Hopkins Center for Psychedelic and Consciousness Research, Mr. Mike Moulette, Chief Operating Officer at the Multidisciplinary Association for Psychedelic Studies, Public Benefit Corporation, Dr. Raji Ramchand, Co-Director at the Rand Epstein Family Veterans Policy Research Institute, Mr. Brett Waters, Co-Founder and Executive Director at Reason for Hope and Co-Founder of the Veteran Mental Health Leadership Coalition, Mrs. Julianne Mercer, Director of Veteran Advocacy and Public Policy at Healing Breakthrough. Sergeant Lebecki, you are now recognized for 3 minutes to deliver your opening statement.
My name is Jonathan Lebecki, and I'm an American veteran. I served 4 years in the Marines, and upon seeing the towers fall, I joined the North Carolina Army National Guard, and I served in Iraq 2005-2006 with 172 members of Bravo Battery, 5th of 113th. Was medically retired in 2009 after a total of 12 years service. As a veteran, I have the privilege to have my trauma be socially acceptable, unlike so many others, because it is easily understood why a veteran who deployed, whose base was shelled almost daily, would have PTSD. As someone who frequently shares their story publicly, I fully understand why so many chose not to share such intimately personal details of their trauma. Most of my story is shared by hundreds of thousands of veterans. I'm but one voice of many. I grew up in a house where my siblings were abused, where one of my siblings suffered from addiction. Like so many, I left for boot camp because I wanted to help people and to escape. After all I saw and experienced in Iraq had cracked my mental health, I returned home to find my house empty, my dog gone, and my wife living with someone else. So in the early hours of Christmas morning, 2006, less than 2 months after returning home, after going to Sacred Heart Church in Raleigh and being turned away because they were full, going to Womack Army Medical Center and being told to come back after the holidays, and I was sent home. I did what 136 Americans do, including veterans. I tried to end my life. I put a gun to my head and I pulled the trigger. I forever remember the peace I felt as the hammer fell, because it would all be over at last. I heard the pop. I thought I was dead, but the pain was still there. It was then that I realized that the ammunition malfunctioned. That was the first of 5 suicide attempts that should have been successful. That doesn't include the daily ideation, the hundreds of times I stood on a bridge. Following my last attempt, I was passed a note from an USC intern that said, Google MDMA PTSD, and I did. And I discovered that MAPS PBC was conducting a clinical trial in Mount Pleasant, South Carolina, just across the bridge. It was the 26-person and a 25-person study of veterans and first responders. I went through a clinical trial lasting about 4 months. I took MDMA and sat with trained therapists for 8 hours, only 3 times. To be clear, I've only taken MDMA 3 times in my life, 9 years ago. The MDMA doesn't fix anything. Like anesthesia, it puts the mind, body, and spirit in the place it needs to be so that therapy can work. Much like when I was given fentanyl prior to my back surgery, the anesthesia didn't fix my back, the surgeon did. For the first time, I was able to freely talk about my demons without my body betraying me. With the help of Michael and Annie Mithofer, I not only worked through my trauma from Iraq, but my whole life, and excised those demons for good. The VA in their formulary currently has exceptionally powerful drugs such as ketamine, fentanyl, and a long list used as anesthesia that the VA has been able to properly handle and use in a medical environment. MDMA-assisted therapy is the same and objectively safer than many of those drugs. And through a guiding hand, I've been placed in circumstances where if I was not healed, I would have cracked. For example, attempting to rescue a drowning victim in my backyard, attempting to save a gunshot victim in Charleston, and most recently providing humanitarian aid on the front lines of the Ukraine-Russia war. I am not special. My story is the same as every other veteran suffering with PTSD. My story changes because I went through MDMA-assisted therapy. I was blessed by being able to participate in a clinical trial. Most veterans face the choice of leaving the country that sent them to war, the country they love, they have shown they will die for so they can heal, because otherwise they will sacrifice their life for this great country, far from a battlefield, at home, alone in the dark. The only entity that can ensure that all veterans have access to the same treatment I went through in a safe and effective manner with trained therapists and medical-grade substances is the VA. I measure my failures by the list of people I know who have committed suicide. It hangs on my fridge. We as a nation have left these veterans to suffer. We have left them behind. It is beyond time for this country to mean it when they say we don't leave anyone behind, and ensure that there are more sons and daughters, mothers and fathers, and fewer loved ones left with nothing but a folded flag. Because I know that the sole reason my son has a father instead of a folded flag is because I went through MDMA-assisted therapy. Every veteran who is suffering from PTSD and is at risk of suicide should have access to the treatment I received by going to the VA. I vehemently oppose the idea that you can achieve the same results that I did by removing the therapeutic component and using untested and potentially lethally tainted drugs. Veterans have earned the right to heal by doing what this august body asks them to do. It is unconscionable to prohibit research, given where the science and evidence currently sits. Every time I made the choice to end my life, it was because I had lost all hope of a better day. Hope of a day like I now have every day. Because I share my story publicly, I often have veterans reach out begging for help for access to the treatment I went through that saved my life. I am now begging the veterans on this committee and for the whole of Congress to please give them hope of a better day. We all know it won't be tomorrow, but I beg for you to give them the hope of someday. And I thank you for this opportunity, and I stand ready to answer questions.
Thank you, Sergeant Lebecki. Dr. Barrett, you are now recognized for 3 minutes to deliver your opening statement.
Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee, I thank you for the opportunity to testify today. I'm Dr. Frederick Barrett, Associate Professor of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine, and I am the Director of the Center for Psychedelic and Consciousness Research at Johns Hopkins. I'm providing testimony as an individual and not as a representative of any institution. The following are my own views and not necessarily those of Johns Hopkins University, Johns Hopkins Medicine, or the Psychedelic Research Center. I've been conducting human research with psychedelic drugs in healthy individuals and patients with mood and substance use disorders at Johns Hopkins for 10 years. This program of research was initiated by my mentor, Dr. Roland Griffiths, who published the first psilocybin administration study in the modern era in 2006. The study is widely recognized as the study that reignited and catalyzed academic and medical interest in psilocybin. Since then, dozens of peer-reviewed empirical reports of clinical trials have been published testing the safety and potential efficacy of psilocybin and closely related compounds to treat patients with a wide range of psychiatric disorders, including mood, substance use, anxiety, obsessive-compulsive, and other disorders. Notably, 2 FDA-regulated multi-site phase 3 registration trials are currently underway to determine whether psilocybin can be approved as a medicine to treat patients with depression. We also come at a time when FDA is also considering whether to approve the related compound, MDMA, for the treatment of patients with post-traumatic stress disorder. Depression, substance use, PTSD, and trauma writ large are leading causes of disability that plague our veterans as well as citizens at large in this country and around the world. I urge the committee to do everything in their power to facilitate the careful and thoughtful evaluation and implementation of these therapies, and importantly, the expansion of access to these therapies to as many veterans as possible in the event that they receive FDA approval. Evidence to date demonstrates the relative safety of psychedelic drugs to appropriately screen individuals in controlled settings, but these drugs do have known risks. These risks are well managed and mitigated for properly screened individuals when under the care of trained therapists. And within these procedures, we have safely administered nearly 1,000 doses of psilocybin to well over 400 individuals at Johns Hopkins since 1999. While incredibly promising, psychedelic science is still underfunded, hidden behind some restrictive regulatory barriers, and not well understood by clinicians, policymakers, and the general public, so I'm grateful for you all for doing your due diligence and hosting these panels. But I think there are clear next steps that can be taken to address these deficits. I urge the representatives of this committee to support programs that will allow the education of at least stakeholders, if not the general public, about the risks and the potential therapeutic benefits of psychedelics. These will be incredibly important, especially in the context of local ballot initiatives and state legislation that seek to kind of circumvent the FDA and the federal processes. I also urge the representatives of this committee to consider funding initiatives that will not only foster a greater level of investment in psychedelic therapy in the VA and research in the VA, but also more broadly within academic medicine, law, and public policy. And finally, I would like to urge the representatives of this committee and the House to support the bipartisan and bicameral Breakthrough Therapies Act introduced by Representatives Mason Dean as well as Senators Paul and Booker. This act proposes the Schedule I compounds that are granted breakthrough therapy designation by the FDA be automatically rescheduled to Schedule II, which will substantially ease the burden of academic research into these compounds while not substantially increasing risk to the public, especially in the case of psilocybin and MDMA. Thank you for this opportunity to speak on this topic that I believe has such great import at this time. Thank you.
Thank you, Dr. Barrett. Mr. Millett, you are now recognized for 3 minutes to deliver your opening statement.
Chairwoman, Ranking Member, and Subcommittee members, thank you for your leadership in holding this first-in-kind hearing on emerging therapies and their potential for treating veterans suffering from PTSD and other mental health conditions. On behalf of MAPS Public Benefit Corporation It's a privilege to be here. My name is Mike Millett, and I'm the Chief Operating Officer of MAPS Public Benefit Corporation, a public benefit company working to change the way mental health conditions are treated. The mission is personal for me. For the past 2 decades, I have seen my wife, who's a therapist, struggle to find effective solutions for her patients with PTSD. I joined this company with the goal to help my wife, healthcare providers, and patients ultimately have access to new treatment options. PTSD is a mental health condition affecting approximately 13 million Americans each year. However, currently available treatments only provide modest efficacy. Disproportionately impacting veterans, 7 out of every 100 veterans will have PTSD at some point in their life. Despite growing mental health needs, there has not been significant innovation in decades. At MAPS PBC, we have made significant progress at researching a new investigational treatment for PTSD known as MDMA-assisted therapy. It's an acute treatment that entails a unique combination of talk therapy and medicine. In our clinical studies, the participants received either MDMA and therapy or a placebo and therapy 3 times over a 12-week period with 3 therapy sessions in between each medication session. In 2017, the FDA granted MDMA-assisted therapy breakthrough designation, which is a process designed to expedite the development of drugs intended to treat serious conditions with preliminary clinical evidence that indicates a potential improvement over available therapies. Both of our phase 3 clinical trials, which were designed under a special protocol assessment with the FDA, met their pre-specified primary and secondary endpoints and were published in Nature Medicine. In these studies, participants in the MDMA-assisted therapy group experienced significant reduction in PTSD symptoms versus participants receiving placebo therapy. MDMA-assisted therapy also offers significantly reduced clinician-rated functional impairment, which was measured by the change in baseline in the modified Sheehan Disability Scale. This scale measures impairment in functions in 3 areas: work, social, and family life. No serious adverse events were reported in either the MDMA group or the control group. We are pulling together all of the data and preparing to submit our new drug application to the FDA by this year's end. If successful, we anticipate MDMA-assisted therapy for the treatment of PTSD could be approved by the FDA next year, making it the first emerging therapy of its kind available to patients suffering from PTSD. The Veterans Administration has the opportunity to create innovative care models to ensure treatment for PTSD are scalable, accessible, and importantly, covered in a timely manner for veterans in need. Thank you again for your leadership on this issue and your continued commitment to the health and safety of veterans.
Thank you, Mr. Millett. Dr. Ramchan, you are now recognized for 3 minutes to deliver your opening statement.
Chairwoman Miller-Meeks, Ranking Member Brownlee, and members of the subcommittee, thank you for the invitation to testify. My name is Dr. Rajiv Ramchand. I'm a senior policy researcher at the nonprofit, nonpartisan RAND Corporation, where I co-direct the RAND Epstein Family Veterans Policy Research Institute. I will focus on 2 critical areas for policymakers to consider as we learn about the benefits and risks associated with psychedelic-assisted therapies. First, continued investment in research is critical. There currently are good treatments available for conditions like PTSD, but they do not work for everyone. There is a need to invest in research to develop new treatments. This includes adequate funding for the National Institutes of Health and research programs within VA and DoD. Federal investment is necessary because private funding for novel therapies for mental health conditions is waning. Congress can also make the process for conducting research on psychedelic compounds more efficient, relaxing the notoriously time-consuming, confusing, and expensive processes required to conduct research on Scheduled I drugs would expedite research into psychedelic-assisted therapy and help get novel treatments to veterans more quickly. Second, policy solutions are needed to address potential barriers to veterans' abilities to access psychedelic treatments if and when these treatments become available. The first potential barrier is cost. If and when available, MDMA-assisted therapy will not be cheap, especially in the early years. Evidence from Oregon and Australia suggests that the price of these therapies will be high enough to be a barrier for many veterans, particularly those who want care outside VA. Veterans who can't afford MDMA-assisted therapy may try to access it in illegal markets where a dose is cheaper but could include dangerous adulterants like methamphetamine. A second access factor will be whether VA has the workforce and resources to provide MDMA-assisted therapies within its behavioral health infrastructure. VA would need to determine who should deliver this treatment and how to accommodate a more time and labor-intensive protocol while simultaneously meeting expectations to provide care to veterans in a timely manner. If VA considers paying for this care through its community care network or new partnerships, it will need to consider which firms in an emerging market have lasting power, as well as how to assess whether veterans are able to access this care in a timely manner. The final issue related to access is quality. If VA providers deliver this care, VA must decide how closely to adhere to the FDA-approved protocol and how to monitor its own providers' adherence to it. VA currently has no process for monitoring quality of care veterans receive in the community, creating yet another hurdle to outsourcing this care. Regardless of whether it provides or pays for it, psychedelic-assisted therapy is becoming increasingly available. VA should prepare its providers to talk to patients about and encourage veterans to speak with their providers about their interest in these treatments without fear of losing VA benefits. In conclusion, psychedelic-assisted therapy holds great promise, but their full benefits will be realized only with continued investments in research, improvements in access to these compounds for research purposes, and careful planning for how this care can be offered to ensure that all veterans who need and want these treatments can benefit from them. Thanks. I look forward to your questions.
Thank you, Dr. Ramchand. Mr. Waters, you are now recognized for 3 minutes to deliver your opening statement.
Chairwoman Miller-Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee. Thank you for the opportunity to testify today on behalf of Reason for Hope and the Veteran Mental Health Leadership Coalition. My name is Brett Waters, and I'm the co-founder and executive director of both organizations, which are led by retired Marine Lieutenant General Martin Steele. I'm also a multi-generation survivor of suicide loss, having lost my grandfather, a World War II veteran, when I was young, and my mom, Sherry Hope Waters, 5 years ago. Reason for Hope is named in her memory. We are here today because a growing body of evidence suggests that psychedelic therapies can provide rapid, robust, and durable relief and healing to individuals suffering from a variety of mental health conditions, particularly those who have not benefited from existing options. Significantly, the Food and Drug Administration granted breakthrough therapy designations both to MDMA-assisted therapy for PTSD and to 2 psilocybin therapies for treatment-resistant depression and major depressive disorder. This means that the FDA hopes to accelerate the approval timeline for these potentially life-saving therapies as they demonstrated a substantial improvement over currently available treatments for these conditions. However, the Schedule I status of MDMA and psilocybin under the Controlled Substances Act slows down the necessary clinical research and has resulted in a lack of public funding needed for such large-scale trials. Schedule I also blocks compassionate use under the Right to Try Act, including for veterans who do not qualify for clinical trials in the United States due to their complex conditions. A tragic result of this flaw in our regulatory system is that veterans have been forced to either leave the country or risk criminal penalties at home to access these potentially life-saving treatments. This is morally unacceptable, and we can absolutely do better. That is why we urge the committee to support the Breakthrough Therapies Act, introduced by Senators Booker and Paul and Congresswomen Dean and Mace. We are grateful for the strong bipartisan coalition that has championed both bills, including you, Chairwoman, as well as Congressman Luttrell. The Breakthrough Therapies Act is simple. It moves Schedule I drugs that the FDA designates as breakthrough therapies or approves for expanded access from Schedule I to Schedule II on an expedited timeline. At no cost to taxpayers, this bill reduces onerous barriers to innovative research and enables compassionate medical use of breakthrough therapies, including under the bipartisan Right to Try law. It's an essential step to accelerate access to potentially life-saving treatments, particularly for veterans who don't qualify for clinical trials in the United States. It seems obvious that our nation's heroes should not be forced to leave the country that they selflessly served in an attempt to save their own lives. We also urge the committee to ensure sufficient funding for large-scale VA research programs that better reflect real-world settings, as well as funding for education and training of providers, including veteran peer supporters, in this specialized form of care delivery. While our coalition has sought to do its part by helping to unlock over $12 million in state funding this year for these purposes, it is critical that the federal government and the VA step up and take a leading role to protect the future of our veterans. Thank you for your time today, and I look forward to answering your questions.
Thank you, Mr. Waters. Ms. Mercer, you are now recognized for 3 minutes to deliver your opening statement.
Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee, on behalf of the millions of veterans who suffer from PTSD and the organization that I represent, Healing Breakthrough, thank you for the opportunity to provide remarks on the great hope that MDMA-assisted therapy holds for those living with chronic, complex PTSD, a leading cause of veteran suicide. My name is Juliana Mercer. I'm a 16-year Marine Corps veteran. My military career spanned my 20s and 30s and almost 2 decades of war in which I deployed to Iraq and Afghanistan and served on the Marine Liaison Team at the Wounded Warrior Battalion. After active duty, I dedicated my life to seeking solutions to the veteran suicide epidemic. Over the years, I've lost too many brothers and sisters to the ravages of war, combat deployments, the loss of friends in combat, and the many more lost here at home to suicide took a massive toll on my mental health. Though immersed in purposeful work, I found myself in a place with no purpose. I needed help, and like other veterans, I left the country to access a breakthrough therapy not available in the United States and was able to reconnect to my purpose. We lost 5,461 service members in post-9/11 hostile combat operations, and in the last 2 decades, over 6,000 have committed suicide each year. We have lost more veterans here on American soil to suicide than we have in the global war on terrorism, over 100,000 more. That annual rate has remained consistent over the years, implying that nothing currently on the market or in practice has meaningfully addressed the root cause of PTSD or decreased veteran suicide rates. This is a reality worth repeating because it's what motivates me to fight for my brothers and sisters every single day. Despite billions of taxpayer dollars spent addressing this issue, we are still losing over 6,000 veterans per year. That's more per year than in 20 years of combined wars. If we continue doing what we've been doing, we may be saying the same thing 20 years from now. Thankfully, there's hope on the horizon. An FDA-designated breakthrough therapy known as MDMA-assisted therapy offers scientifically validated hope for veterans who have PTSD. MDMA-assisted therapy trials concluded that after 3 sessions, 86% of patients struggling with PTSD reported clinically significant reduction in symptoms, while 71% of patients experienced complete remission of PTSD symptoms. The implications of these peer-reviewed trial results cannot be overstated. MDMA-assisted therapy has proven its efficacy in treating PTSD and is on the path to FDA approval next year. I'm here today asking that you lead, as Congress must in such moments of crisis, and continue to urge the VA to implement a nationwide program for this breakthrough therapy as soon as possible. Every day wasted means more lives lost. Thank you for letting me share my story and for allowing me to advocate on behalf of my fellow veterans. Chairwoman Miller Meeks, Ranking Member Brownlee, this concludes my testimony. I would happily answer any questions you or the subcommittee may have.
Thank you, and thank you to all of you. And Chairwoman Miller Meeks, as we all do around here, we're juggling between different hearings, meetings, but number one, thank you, all of you, for your honest and heartfelt and direct testimony without bias or prejudice in any way, because you've in many cases lived this. I'll recognize myself for 5 minutes here. And by the way, I just got a couple of questions, and anybody who wants to provide an answer can. Don't feel you have to if you don't, it's not in your wheelhouse. Some critics have pushed fear-mongering comparisons between psychedelic-assisted therapy and state medical marijuana programs, where individuals can often take home essentially limitless amounts of the substance, in this case, some form of cannabis, with doctor approval. Given your experience and what we have heard from Dr. Yehuda in the previous panel, is this a fair comparison? Jonathan?
I think a lot of that has to do with the context of use. If it's done at a VA or in a medical facility under proper supervision, I think it's a very inappropriate comparison. For one, I'll be honest, I used cannabis for 5 years to abate suicidal ideation, and it was highly effective. And when I moved to South Carolina and could no longer do that, everything came back. I did MDMA-assisted therapy 9 years ago, and I haven't taken any mental health medication since.
Okay. Anybody else? Again, we see when this topic first came up, there were entities that tried to scare our colleagues. Mike?
Thank you, Congressman. I think it's important to note the way in which MDMA-assisted therapy would be delivered in a clinical practice or within the VA in this instance. First of all, as Dr. Yehuda had mentioned earlier, medicine is provided on a one-time treatment basis, meaning it is delivered one set of medication for one treatment session at one time to individuals in a healthcare setting to be taken in the presence of a healthcare provider. That would be repeated 1 month later and then 1 month after that. So it's really important to understand that the delivery of this product will be very well controlled if approved by the FDA. And we also anticipate that a REMS program, a risk evaluation and mitigation strategy, will be implemented by the FDA as well, further refining the way in which we can deliver this product one at a time in front of a healthcare provider.
Okay. Anybody else?
I would just note that there is a lot of activity happening at the state and local levels concerning hallucinogenic deprioritization in their criminal justice kind of efforts. So I don't think the comparison, I think the medical purposes is really well intentioned and guided at this, but this is happening at the same time that there's a lot of legislative action happening that may make availability of psychedelics may make psychedelics more accessible just due to what's happening at state and local levels.
Okay.
So I think one of the critical components to the legislation that I've referenced, as well as Dr. Barrett, with the Breakthrough Therapies Act, in terms of reducing the barriers to research and compassionate use by rescheduling from Schedule 1 to Schedule 2. One of the key things that could come about from that is kind of preventing that state-by-state approach and the kind of ballot initiative or legislative legalization, whether for medical use or recreational use, that we saw with the rollout to cannabis, because one of the critical and very valid talking points for many people who are suffering is that some people just don't have time to wait, and maybe they either can't leave the country or they don't have the financial resources to do so. And by rescheduling and making it easier both to conduct clinical trials, to get funding for those trials, and to ensure compassionate use is at least available to those who might not qualify for ongoing trials, that's a critical way that we can make sure through the medical system that this is legally available to people and can actually prevent some of that state-by-state approach that we've been seeing.
Okay. Juliana, any thoughts? You don't have to.
I think it's important to note that with the cannabis, it's self-medication, and with the MDMA, it's under the care of a healthcare provider, and it includes therapy that helps you work through your problems.
Okay, thank you. Sometimes when we don't understand something, we fear it, and one of the goals of our committee, both sides of the aisle here, is to take the temperature down, get rid of the fear-mongering, and get right into the realistic research and the outcomes that we know are potentially available. In fact, when we developed the PATH caucus, we added GOOD to it. You got to have good acronyms here in DC, but GOOD stands for Get Off Opioid Dependency. 1, 2, or 3 and done, not a continual life of medications. And I can guess, but I'm just going to ask the question, you just give me a head nod. Can we give veterans access to these promising new treatments without legalizing recreational use of psychedelics? Okay, thank you. And with that, Ranking Member Brownlee, I yield to you.
Thank you, Mr. Chairman, and thank you to the witnesses for being here. I wanted to ask all of you the same question I asked on the first panel with regards to if there's any awareness of clinical trials having to do looking at effectiveness on women veterans versus men veterans with these kinds of therapies, if you're aware of any research or trials that are going on.
So thank you very much, Ranking Member Brownlee, for the question. There is a distinct lack of a clear scientific record in human clinical trials comparing the effects of MDMA, psilocybin, or other psychedelics between those with different biological sex. I can say that I just came from the Society for Neuroscience conference where I chaired a press conference demonstrating a number of preclinical animal model trials that demonstrate potential sex differences in the response to psilocybin and other psychedelic drugs. But this has not yet made it to the level of human clinical trials, and I think it desperately needs to.
Thank you. I couldn't agree with you more. Thank you very much. Sergeant Lubecki, thank you for being here. Thank you for your testimony. I think you've made it clear after 9 years of therapy that you're healed, not cured. Is that an accurate way to express it?
Yes, ma'am. I mean, there's nothing that, if I had a traumatic experience, would say I wouldn't get PTSD again, but I am currently PTSD-free, even after all the traumas that I outlined in my testimony, which have happened in the past 9 years.
So does that mean that the triggers before you had the treatment, the triggers that would lead you to want to take your life and other things, are those triggers, have they just disappeared, or do you know how to deal with them in a more effective way? I'm kind of curious to know exactly how that works.
Well, I think the best way to answer that question, ma'am, is the 4th of July before I took my first MDMA dose. I was in South Carolina. They love their fireworks. And I was in a closet in my body armor having flashbacks of Iraq with my service dog. This past May, on my last trip to Ukraine, as with every trip, Kyiv came under fire. This is where I learned air raid sirens are the same all over the world, unlike police sirens, which change from country to country. But I was able to, once I assessed the situation, made sure my building wasn't damaged, there was nobody hurt around me, I rolled over and went back to sleep and didn't have any nightmares. And I haven't had any nightmares like that since I've been home either. The triggers still exist. There's still people dropping bombs in this world. They just don't affect me the way they did. I have a proper emotional response, and then it doesn't come up again.
Thank you for that. And again, thank you for being here. Dr. Ramchan, I think we all agree that, all of us here agree that we need more research. Research is obviously very, very critical. I wanted you to speak to why it's so important that the VA is funding research for veterans, and veterans specifically. If you could just speak to that.
I mean, the VA has a huge Office of Research that, in order to access care, I mean, I think that this was described in the first panel. The clinical practice guidelines said that there weren't enough veterans enrolled in trials. They didn't have enough evidence for veterans. That was one of the reasons that they haven't kind of prioritized, at this point, psychedelic-assisted treatments. I think that the VA is the natural place to conduct research on veterans. So if that's going to be held as a criteria for making policy decisions about the availability of these compounds, then I think the VA needs to be at the forefront doing this research, and that's why we need to invest in research within the VA.
I agree, and I think that suicide rates are higher in the veteran community. They have different health issues that aren't necessarily consistent throughout the general public. I personally think it's really critically important that we focus on the community of veterans, both men and women. Women are the fastest growing cohort within the veteran community. Thank you for that. And last, I'll ask Ms. Mercer. You've talked about, again, more research. I think the question that I just wanted to ask you about is what do you see as the key things for the VA and the committee to focus on the very near term?
The VA needs to be prepared for the logistical challenges around implementing a novel treatment. We've worked really closely with VA stakeholders to identify some of these critical logistical challenges and potential solutions. They're going to need to train thousands of clinicians. They're going to need to find the right facilities, the room where they're going to be able to access for over 8 hours to be able to facilitate this treatment. There's going to need to be education and outreach to both staff and to patients. So there's so many things that need to be done before they're able to be successful in implementing an MDMA program.
Thank you. I yield back, Mr. Chairman.
Thank you, Ranking Member. There was a very good question or statement in quite a few of your opening remarks. Mr. Waters, I'm going to start with you, and then Dr. Barrett, I'm going to shift over to you. The rescheduling from Schedule 1 to Schedule 2, and this is not a debate, but open for interpretations on your behalf. We are in our infancy. Though these efforts have been around for a while, Mr. Barrett, we are surely in our infancy. My concern in the conversations that I have quite often on the direction that we're trying to take is the rescheduling and the concern of the expansion away from what we're trying to accomplish. Do you think the rescheduling from 1 to 2, do you think we're in a place that is necessary to happen right now, Mr. Waters, or is that something that longitudinally we can bring out with the VA's help, as we're working in parallel with them? Is there a time frame?
I believe it is necessary and it is logical that it should happen now because the way that the system currently works is that after FDA approval, these products automatically have to be rescheduled within 90 days. So the advantage that we get by rescheduling at this point, before these are FDA approved for use in interstate marketing, and we'll be seeing these on commercials, there's a interim step in the process where we will make it easier to do research, to fund that research, and to enable compassionate use of these treatments that will be able to help build up the evidence base and give us a better understanding of their use in real-world settings. But the move from Schedule 1 to Schedule 2 really is pretty small. There's no change in criminal penalties, other, for
You'd be surprised how not small that move is on our side.
Well, for the barriers to research, it is significant, and for compassion.
I understand and appreciate the research aspect of it. I'm just saying, on this side, that is a very large boulder to shove.
Sure.
I'm sorry, go ahead.
There's otherwise, because these are not approved treatments yet, they're not going to be available to be marketed in widespread use, but that is certainly where we are. Hopefully going to be seeing MDMA in very short order, hopefully by early 2025.
Mr. Barrett.
Thank you for the really important question, Representative Luttrell. And I, of course, make no claims to be a policy maker or understand the intricacies therein, but I do acutely understand the barriers to research. And I have to say that one of the largest barriers to entry of some of the most qualified scientists in the world to be studying these things is highly tied up in obtaining approval for using Schedule I substances in research. The barriers for using Schedules 2 through 5 are far lower, and my understanding was that it would make this not only far more accessible to incredibly qualified researchers who it may be very difficult to access otherwise, but this would speed the process of answering the multitude of very important questions that we still haven't answered that have been asked in this panel today and in this hearing, including, well, what about repeated dosing? How long will the effects last? What's the schedule? What is the exact appropriate dose for a given individual in a given population? And what about all of these other compounds? And I can go on for days about how many questions we don't have answered. And frankly, having this move and allowing for greater research before approval would make the post-approval world safer, possibly more effective, and possibly easier to implement. Of course, this is speculation, but that is my initial response.
I think there's just so many little nuances that we need to run and breast with each other. If anything gets out in front that shouldn't be, we will lose this like we did back in the 60s. And that is not somewhere where we need to be and where we need to go. But thank you for those answers. I'll move it over to you for closing statements.
This has been a very important hearing, hopefully the beginning of many more to stay on the trajectory of getting to where we would, I think, all like to get to. And so I really thank the witnesses here today for, first of all, being here, for doing the work that you are all doing to move these therapies forward. I'm a believer, but we do need to do more research. We do need to make sure that we've got all of our, that everything is in place, and all the, I think, Ms. Mercer, you talked about all of the logistical things that need to get done. I think those are really good suggestions in terms of training and everything else that we can begin to be doing now in anticipation of. So I just, very, very grateful, really, to all of you. And Sergeant Lubecki, thank you particularly for being here and sharing. It's always, I think for all of us here, it's really important to hear from our veterans, hear what the impacts are, and your kind of personal assessment of this. So I can imagine that as you speak to so many other veterans, how desperate many are to have the same kind of experience that you were able to have. So it's our obligation to try to meet those needs, and thank you all very much.
Thank you, ma'am. I would like to thank everyone for their participation in today's hearing and for this thoughtful examination of emerging therapies and their potential promise in combating veteran suicide. For many, this is a new and challenging topic, but I hope that this oversight hearing provided the measured discussion vital to ensuring policymakers have the needed background and scientific information with regards to potentially life-saving therapies. My colleagues and I are committed to serving our veterans and doing everything possible to move the needle in addressing the suicide and substance abuse crisis. This committee will not shy away from exploring new avenues and approaches in this fight. I appreciate everyone's willingness to come here today and for their input. Above all, thank you for your work serving our veterans. I look forward to the continued achievement and advancements in science and will be watching this space closely in the coming months and years. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections so ordered, I thank the members and the witnesses for their attendance and the participation today. This hearing is adjourned.